Welcome to the Neuromodulation Podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare. Welcome to the Neuromodulation Podcast. I'm today's host, Mandy Soleil, and it's a pleasure to be here with you. On today's episode, we're joined by Dr. Diana Martinez, professor of psychiatry at Columbia University Medical Center, and a leading psychiatrist in addiction research and therapeutic innovation. Dr. Martinez's work sits at the intersection of clinical psychiatry and translational science, with a focus on repurposing evidence-based treatments for other challenging and often underserved conditions. Her current research portfolio spans several innovative areas, including investigating ketamine for the treatment of tinnitus, conducting a clinical trial of cannabinoids for taxane-induced peripheral neuropathy, and exploring transcranial magnetic stimulation, or TMS, for alcohol use disorder and chronic pain. In this conversation, we'll explore her journey into neuromodulation, what the evolving role of brain stimulation in addiction and pain research is, and what it takes to move from established therapies to new therapeutic frontiers. Thank you for joining us.
Thank you. Thank you for having me. Glad to be here.
So I'd love to hear, you are taking a bit of a unique approach to transcranial magnetic stimulation, or TMS, in that you're addressing substance and alcohol use disorders pretty readily. How did you end up following that path?
So I'm a psychiatrist, and I've done research since residency, which was in the last century. So I've been doing research for a very long time in substance use disorders. I actually started out doing research in schizophrenia, but moved pretty quickly to substance use disorders, addiction, and really started out doing a lot of pharmacology. I did a lot of PET imaging, looking at different receptor systems, the idea being that I wanted to develop a medication that would be useful for alcohol or cocaine use disorder. And I did that for over a decade, and really came up, myself and colleagues, with medications that would be useful for substance use disorders, and realized that without the pharma industry being interested, that this wasn't going to go anywhere. And I had a lot of very hard meetings with companies where they essentially told me that they really weren't going to pursue substance use disorders, despite the fact that we had good ideas for them. So I completely changed my career and just decided that I wasn't going to do this anymore, and I had to do something completely different. And it was hard. My brain thought in terms of receptor systems and chemistry and affinity and agonists and inverse agonists and all that type of stuff. And I decided to switch to neuromodulation because I knew I could at least get access to these tools. And I didn't have to wait for a pharmaceutical company to decide that they were interested in substance use disorders as well. And there was this profound meeting that I had. I was in Italy for a meeting, and I got there. You do the overnight flight. So I'm there like early, and the room isn't ready, and I'm exhausted, and I'm all bleary-eyed, and I'm sitting in the cafe, and a man sits down next to me who looks like he's in the same boat, and we strike up a conversation, and it happened to be Bumi Zengin, who is one of the inventors of the H-coil for TMS, and that's how I got into TMS. We started talking about, he said to me, I have this coil, I don't know what to do with it. It targeted the medial prefrontal cortex and dorsal anterior cingulate. I'm like, I know what to do with it, and that's sort of how it got started.
So today we're going to talk a good bit about alcohol and substance use disorders. So I want to start off from your perspective as a psychiatrist. Can you define what those are?
Sure. So the simplest definition of a substance use disorder is drug use that's out of control. And that means the use of substances or drugs that have adverse consequences. That's kind of the simplest definition. And, for drugs, we mean alcohol, cannabis, nicotine, tobacco, cocaine, opioids. There's many of them. We call them all just sort of under the rubric of substance use disorders. And we have a number of criteria that we use to define or diagnose a substance use disorder. There are 11 criteria. Interestingly, none of the criteria have anything to do with the amount of use. So, for example, we're all familiar with like social drinkers and people have alcohol problems, and we tend to think of it in terms of the amount of alcohol that's consumed. And certainly the amount plays a role, but when we're diagnosing a substance use disorder, we really pay attention to the pattern of use. And the pattern of use has to do with things like failed attempts to cut down, use of alcohol or cannabis or any other drug, and not meeting obligations. Those obligations can be at home, work, or school. The use of a substance that causes mental or physical health problems. And oftentimes, we think of this, you might think of like liver disease and alcohol use disorder, but really, even a cannabis use disorder can cause things like insomnia or anxiety or agitation. So they can really be sort of more mild medical problems or psychiatric problems that we're thinking of. And also, the typical ones are really tolerance and withdrawal. When somebody has tolerance to a drug, they have to take a lot more of it to get the same effect. If they stop taking it, they'll feel withdrawal symptoms pretty quickly. And those withdrawal symptoms, like the medical problems, don't have to be particularly profound or exaggerated. They can be mild as well.
Something that's also interesting to me about your work is that you both support people with cannabis use disorder, but then you're using cannabinoids in some of your research. Can you share what your perspective on this sort of dual prong approach, where it's both something that can be a disorder, but also a medicine?
Right. So we've been doing some research with cannabis, and actually we have a paper that I have to get out the door. We're using cannabis for chemotherapy-induced peripheral neuropathy, or CIPN. And CIPN is difficult to treat. It's almost impossible to treat. It can be pretty profound, and people sometimes stop their chemotherapy because of it. So it's profound loss of feeling in the hands and feet. And there are rodent studies that show that cannabinoids, THC and CBD, can help. So we just did a clinical trial on that, and what we saw was an improvement in some of the symptoms of neuropathy. So that's the way in which cannabis might serve as a medication. Now, somebody who has neuropathy and is struggling to finish their chemotherapy, that person I would treat with a cannabinoid. They would treat with cannabis because it's I have no other choice, and my choices are this person may not finish their chemotherapy, or this person may have a lot of disability because of the loss of the feeling in their hands and feet. If I'm talking about a young person, a 20-year-old with anxiety, and cannabis makes them feel better, I wouldn't use it to treat that person. So that's the thing we have to keep in mind with substance use disorders. I don't want somebody who's 20 years old and has anxiety and using cannabis for that, using it in a way that often escalates or becomes unsafe. Or also, when you use cannabis for something like anxiety, it can be effective at reducing the symptoms of anxiety, but the symptoms of anxiety will come right back once the intoxicating effects of cannabis go down. So we're familiar with this with alcohol. Like, you're stressed out, you have a stressful day, you have a drink with friends, your anxiety levels, your stress levels go down, but once the intoxicating effects of alcohol go away, the symptoms come right back. So that would be a problem when we're treating somebody who's young with cannabis for something like anxiety or depression. If I'm treating somebody who's struggling with chemotherapy-induced peripheral neuropathy and a profound medical problem, I'm less concerned about the cognitive effects. And if they're older, I'm also less concerned about them developing an addiction. So it really, this is the whole science behind it, right? Or the art of medicine is it depends on who and their circumstances.
And I think there's a complexity in that in some areas now, at least in the United States and as well as abroad, cannabis is legalized. And on top of that, people do have a perception of it being associated as a medicine. So then the idea of it being something that you can be disordered in use with can be complicated for people to digest. But I think of it similarly, if you look at like opioid use disorder, right? We understand that very quickly. So this spectrum of the impact on our lives seems like it's an important angle to consider.
Absolutely. And some people are at bigger risk than other people. If they have a family history, they're at bigger risk. If they have a psychiatric disorder, they're at bigger risk. So you have to take those things into consideration when you're considering a substance that can be potentially abused as a medication versus a threat or a threat of harm to well-being.
Then we look at other solutions, and you stumbled into, sounds like by serendipity, TMS. Can you tell me a little bit more about the research that you're currently doing and what the parameters of the study are?
Sure. So we did a study a number of years ago looking at cocaine use disorder and TMS. And it was an interesting study. It wasn't a clinical trial. So before we do research that's a clinical trial, in our group at Columbia, we do what we call lab studies. So in these studies, we have individuals with cocaine use disorder. They come into a research hospital for a month. We have them go into a lab, and we give them a choice between taking the drug and getting money. So we're clearly taking people in the studies who are not seeking treatment, not ready for treatment at the time. They always know they can come back to us. We will set them up with treatment at a later time. And we give them a choice literally in the lab between a dose of smoked cocaine and $5. And the dose of smoke cocaine is about 12 milligrams, which, if you know what you're doing in New York City, is worth $5. In other words, the $5, the choices of way to the $5 is worth more than the 12 milligram dose of cocaine. And we just look at how many times somebody chooses cocaine versus money. And then they went to a lab and we did TMS every day for 3 weeks. And at the end of the TMS, we went back into the cocaine lab and said, okay, what is your choice between cocaine and money? And what we saw was that TMS could decrease the number of choices that people made for cocaine and shift their choices towards the money. And from there, we published that some time ago. We did a study a long time ago. We submitted a grant, I think, 3 times and didn't get it funded and sort of put on a back shelf. In the meantime, we did do some research with alcohol that's still ongoing and with cannabis that's still ongoing. These are mostly my faculty and fellows who are doing those studies. And then I had a junior faculty member really wanted to do the cocaine TMS study, so he kind of dusted it off and rewrote it, and we submitted it, and it's funded. So now we're on, and that's a clinical trial. So that's with people who are interested in treatment for their cocaine use disorder. We don't give anyone cocaine. This is like a full-on, treatment. Everyone gets actually CBT, so everyone gets some kind of active treatment, and then half the group gets sham, and half the group gets active TMS.
Well, congratulations on the funding.
Thanks.
Very exciting.
Right?
So something that I'm curious about, because I know you've also explored the brain regions that are impacted by addiction. And can you speak to then, when we look at TMS and how you're applying the therapy, what brain regions you're targeting and how it differs across different types of substance use disorders, if at all?
So, most of my career I've done imaging. Actually, I came to TMS kind of later. So I've always looked at treatments and the way that they impact different regions of the brain. And certainly when we look at imaging studies, there's not sort of one small localized brain region that I can say I'd like to target with TMS. It's really sort of like multiple brain regions, kind of large brain regions, mostly the medial prefrontal cortex and anterior cingulate were the regions I was interested in targeting with TMS. And for that reason, I actually did all the research I've been doing is with the H-coil, which is bilateral stimulation, and it's a bit deeper than the figure 8 coil, and it's sort of more midline. And that's how we decided on this treatment, because I didn't want to do a study with cocaine use disorder and try and pick a brain region and then have it be the wrong one. So I kind of just took the approach of like, well, let me stimulate as much as I can and see if I have an effect. And, as a TMS research, we put a lot of effort into neuronavigation and finding this one brain region, and I have great respect for that research, but that's not what I'm interested in. What I'm interested in is, can this move to the clinic? And can this help people who are struggling with addiction? And how do I make it more accessible and more available?
For people who are leveraging TMS as a treatment for substance use disorders, is there, obviously we're working on stepping back from having a substance use disorder, but then there are also degenerative impacts of substances on the brain over time. Do neuromodulation therapies, to your knowledge, have any effect in repair?
A good question. We don't actually know. Yeah, we really don't know. I mean, certainly animal models would suggest that it does, but we don't know for sure.
Okay.
So TMS is actually FDA cleared for smoking cessation. That's the only substance use disorder that it's approved for, cleared for, which I think is very exciting. It's not, we were a major site in that clinical trial, that pivotal clinical trial, and it hasn't really moved to the clinic. With depression, TMS, maybe it's just my perspective, seemed to go from research to the clinic, at least at a pace that existed. We're not really seeing that much with TMS for smoking cessation. And I do think one of the reasons for this is we always have this idea, like with smokers, that somehow we still have this idea that somehow it's a choice. That people know they're not supposed to smoke. They see all the ads. They've taught it in school. They know the implications of it. I mean, smoking has serious health consequences, and yet they still do. And so I think that with smoking, maybe even more so than I think with alcohol, we view it as a choice that somebody isn't getting past. And it's often overlooked by clinicians when they're treating psychiatric disorders. And I can tell you, when it comes to depression, a lot of people have comorbid smoking, tobacco, and cannabis as well. And one thing that I would really urge more research on and more clinicians on is to pay attention to the comorbidity between psychiatric disorders and substance use disorders. Most of the time in clinical trials, substance use disorders are excluded when we really need to be looking more and more at comorbidity. And I would love to see more research with TMS and smoking cessation and, its efficacy, but also how it might impact something like depression.
There's something to be said about awareness of something like depression or anxiety. If, say, that's your constant state and has always been that state, something that I've observed in just being alive and connecting with people is that there might be sort of signs or symptoms of depression, but that person doesn't necessarily consider themselves depressed. And so would you say that's perhaps part of an element of this, that there might be comorbidities that are unknown to them?
Absolutely. And people often view themselves as social drug users when they're not. And, we, in my lab, we look at a lot of, we do a lot of work with what we call self-medication, which interestingly was sort of the research community was slow to adopt, but the clinical world is very familiar with this. So the idea being that, like, if I'm experiencing something like anxiety and I use alcohol for it, then I eventually start using alcohol to address my anxiety. And so with self-medication is sort of, it goes hand, this sort of explains why substance use goes hand in hand with psychiatric disorders. It also sort of explains how substance use can become out of control when you have an anxiety disorder or depression or schizophrenia or bipolar, all these other disorders. So if I'm experiencing anxiety and I'm using alcohol to address that, well, my anxiety doesn't just happen when it's convenient or when it's after work on a Friday. It's going to be happening every day, sometimes mornings, afternoons. And so that's how substance use gets to be out of control. The issue we have is that a lot of people don't recognize that they're self-medicating, and they don't recognize when they have a substance use disorder. Usually somebody has to sort of notice it for them, or it has to reach a point where it's really caused a lot of havoc in their lives. So one thing that I think is very important is we need to do a better job across the board in terms of recognizing substance use disorders really early on when they first occur and doing more to treat it when it's a mild substance use disorder. We do it for diabetes all the time, right? We screen everybody for pre-diabetes. We need to be doing the same with a mild substance use disorder.
I think there can also be cultural norms around, you say, maybe being a social drinker, but if that comes as a byproduct of social anxiety, for example, then is it socially using substances or medicating to get through social situations? Is that something that you've observed as a common situation?
Yes. And the issue is, at what point does it go from being social use, self-medication to problematic use? And it's all very gray. We tend to think of like social use, problematic use as there's a clear line, but it's really not. Like people go back and forth between these a lot. People, as most psychiatric disorders, like they get better and they get worse, different circumstances, and the same applies here. So my main point here is that, if we can recognize a mild substance use disorder, which can be something as mild as trying to cut down on your amount of alcohol you take every week and not doing it, and craving alcohol or having tolerance, like those things alone will have you be diagnosed with a substance use disorder. And so we need to do a better job of having the public recognize it and also clinicians. And I would also say researchers in their research sort of looking at this more closely and addressing it in their studies.
So then for treatment, for somebody who's navigating a substance use disorder, we have a broad spectrum of, starting place of mindfulness and meditation, maybe CBT or cognitive behavioral therapy, all the way through to medications and then neuromodulation. Where would you put neuromodulation on this sort of scale or continuum of care? And how do you approach patient selection for something like this?
So it's nice to have an array of treatments, and we know clinically that this is what it takes. If we know if I'm treating hypertension, one medication isn't going to do it. I need different medications with different mechanisms. And for some people, mindfulness or CBT will work well. For other people, it doesn't work as well. For example, and if we're talking, for example, like opioid use disorder, we have to treat with medication. That just has to be a first line. If we're talking about tobacco or nicotine use disorder, I would generally try and get somebody onto medication because the data is just much stronger.
Okay.
So it depends on what disorder, what specific addiction, and it depends on their circumstances. And it also depends on if they have comorbidity. So for example, let's say somebody has ADHD and they're smoking. Well, you need to address the ADHD rather than not just the smoking. So, it becomes a bit more complicated in that regard, but it's certainly nice to have a number of different choices. When it comes to neuromodulation, certainly when it comes to depression, TMS was initially for treatment-resistant depression. And that's usually the case now, depending on your insurance. But, we're sort of moving in the direction where you don't have to have failed multiple medications to get TMS. And I'd like to see that also for substance use disorders, where we don't wait for TMS until somebody's actually not responded to other treatments. If somebody is interested in it and there's no contraindications to it, it'd be great for them to have access to it.
And I'm thinking back now to, I want to say it was a couple years ago now that Stanford released a study regarding major depressive disorder and utilizing TMS, finding that there were neural pathways that could be documented as going backwards in effect, and that they pushed them the other direction, and that this was facilitating a lessening of symptoms or erasure of symptoms of depression. Have you noticed any specific trends like this with substance use disorders?
So we don't have as much data with depression. Certainly Colleen Hanlon has done a lot of this work. She was at MUSC. She's now at Brainsway. She did a lot of work looking at TMS and cocaine use disorder and showing the ability to change the neural networks in this disorder. I don't know as much research being done looking at neural networks with other types of addiction. I'd have to go back in the literature. Certainly cocaine interestingly, cocaine use disorder has been the most studied when it comes to TMS, which is interesting because usually cocaine use disorder kind of gets a little bit ignored. It's difficult to treat pharmacologically. And actually with respect to cocaine use disorder, maybe I should say it's under research. It's been researched a lot, but we had a hard time finding medications that actually seem successful. There's snippets here and there of bupropion or methylphenidate or mixed amphetamine salts might have some effect. But the data with TMS has been remarkably promising when it comes to cocaine use disorder. We still need a large definitive control trial with respect to TMS and cocaine use disorder. That hasn't happened yet. Hopefully that's what we will be doing. But the hints that we have from the literature, and there's no less than, I think, maybe 28 studies at this point with TMS for cocaine use disorder, look very promising, which is nice because we don't have a go-to medication for this disorder.
Something that's jumping out to me with respect to ADHD, cocaine, nicotine is a notable impact on the dopamine system. Do you have any commentary on that, and whether or not there's any research being done specifically around neuromodulation in affecting dopamine and dopamine regulation?
There have been some imaging studies. I would have to go back and look at them per se. Certainly when it comes to ADHD, and this is something I'm very passionate about, when it comes to ADHD, we know that individuals with ADHD are at a very high risk of developing an addiction. And we also know that if we treat the ADHD when they're young as children, we can prevent that from happening. It doesn't happen enough. And I stress out over it because all of my research is in human volunteers with a substance use disorder. And the number of times I see somebody, I have them sit down, we always talk about how their drug use started. It always started in high school. It always reached a boiling point, usually late teens, early 20s. But I would say about half of people, which is consistent with literature, had ADHD as children that was not diagnosed or not treated or not recognized, or was noticed, but no one really did much about it. And then here they are 10 years later coming to see me. And so we just know that, ADHD is an incredibly huge risk factor for developing a substance use disorder. Now, when if we're treating, ADHD definitely is involved with the dopamine system. Substance use disorders are definitely involved with the dopamine system. But both disorders also involve very much the prefrontal cortex and executive control and inhibitory control. So I think that they're all sort of linked together, the way we need to treat ADHD. We tweak the dopamine system, but we really have very major effects on, cognitive control, inhibiting impulsivity, letting the brain take just a little bit of extra time to think things through for few milliseconds, and then act. I don't know if that sort of makes sense. Yeah. I tend to look at ADHD as being a disorder of time, the ability to perceive time, and sort of time blindness, if you will. And what stimulant medications do for ADHD is they just sort of help the brain perceive time a little bit better, so that if you're thinking through a decision, you're also sort of less impulsive. I don't know if that makes a lot of sense, but that's sort of the way I talk about it with my patients, and that's the way they understand it best.
Yeah, it makes sense. And I'm thinking about how In recent years, in my understanding, there's been a notable increase in diagnosis of substance use disorders in the population, at least in the United States, as well as ADHD and various other comorbid conditions. Can you provide any commentary from your clinical work around why you think this is?
I don't think we really know. There's definitely been an increase in the prevalence of, depression, anxiety, ADHD, and substance use disorders never go away. And, I don't think we really know why. I think part of it is better recognition. I think part of it is decreased stigma. Kids these days are less upset about being diagnosed with depression or anxiety, which I think is fantastic. It's very positive. I don't know if rates really changed. We really can't say that yet. We tend to think that these things aren't affected by the environment, but for all we know, we know that if a child grows up in a part of the world where they're more exposed to pollution, they're more likely to have ADHD. So there could be environmental factors, there could be genetic factors, there could be a lot of different things that are feeding into why these diagnoses have increased. I think the important thing is that we're more mindful of them, we're more aware of them, more willing to treat them, more willing to be accommodating of mental health, and really willing to do what it takes to help people have access to care and improve their quality of life.
Can you share about some of the risks for the treatment? So if you're undergoing TMS, what do I need to be considerate of prior?
That's a very good question. I do a lot of talks with clinicians who use TMS to treat depression because there's a feeling out there that if somebody's using substances and you use TMS, you're more likely to have a seizure. And the truth is that's not really the case. So we actually have a review paper coming out. We looked at the risk of seizure with TMS and cocaine use disorder. Part of the reason we did this was because when I got the reviews back from my grant, everyone was like, "You're going to cause a seizure. What are you doing? What's wrong with you?" So we went through the whole literature. And, the risk, certainly cocaine use is itself, independent of TMS, cocaine use is associated with seizure. Most of this research started like in the 80s when there was a lot of cocaine use going on. There's also people like swallowing huge amounts of it to get into the country on airplanes, and then it would burst in the stomach, and then everybody's got in the hospital. So cocaine use itself is associated with seizures, but it's at a very high dose. So all the research we see on it is really if you're in overdose territory with cocaine, that's when you really get the risk of seizures. People who use cocaine on a regular basis aren't going into the overdose range intentionally and not very often because it's miserable. You feel horrible. You have panicked and agitated and high blood pressure and nausea and vomiting and sweating. It's not something that people do intentionally. So the question is, what is the risk of somebody who's not overdosing with cocaine and seizure? And we don't know for sure, but it seems as though it's probably pretty low. So if you're if you're a practitioner or a researcher and you're using TMS and somebody has cocaine use, the likelihood that you're going to cause a seizure is actually very low unless they've used a toxic dose recently. And that you can just ask people. You can sort of do a quick evaluation and see how recently they used, how much they used. Most people will tell you pretty upfront what they used. On the flip side, there's also a concern with alcohol because alcohol withdrawal can cause a seizure. So alcohol withdrawal goes through these, alcohol withdrawal can be quite profound. It can land somebody in an ICU for sure. But the seizure that we see in alcohol withdrawal happens after a lot of other steps have happened. There's a lot of other steps. There's vital sign instability, blood pressure and heart rate go off. There's a lot of psychiatric effects. There's a lot of, again, nausea, vomiting, sweating, all these types of things. So if you're using TMS in somebody who uses alcohol, the likelihood of a seizure is also very low unless they're in withdrawal. So I try to do these talks mostly because I don't want people who use substances or who have a substance use disorder to be excluded from TMS care, to treatment with TMS, because we really can use these safely in substance use disorders. It's the same thing if somebody came in and you're treating them for depression and they had a history of hypertension, you see they're very hypertensive, you might think twice about TMS. It's a similar type of thing. It's a medical procedure and it requires a medical assessment. But the other thing that I worry about is if people know that they might not get TMS if they admit to their substance use and they don't say anything. And that's what we see a lot. I do research in substance use disorders. I've gotten very accustomed to talking to people about their drug use. But most of the time when somebody goes to see a doctor, the first thing they get asked is, do you smoke? And everybody says, no, God forbid. Like, I don't smoke. I'll be honest. I'm going to go see my doctor and like, do you smoke? I'm like, God, no. And like, have you ever smoked? I'm like, of course not. And of course I've smoked, right? I think most people have smoked a cigarette in their lives. So the way we ask the questions about substance use tells people what they have to answer. And the important thing, I think, with TMS and any treatment is, asking these questions in a neutral way so that you really get the responses that you need to hear without stigma and without, making people feel embarrassed about it.
So can you describe what TMS actually is? How is this procedure delivered? What does it look like for somebody who is going through the procedure? How does it physically feel to receive the treatment?
Sure. So, TMS uses a big electrical coil, runs an electrical current through it. That generates a magnetic field. That magnetic field goes through the skull. And then that magnetic field generates a secondary electrical field, which causes brain cells to activate, if you will. So I can put a coil over my own motor cortex and, send little pulses into the part of my brain that controls my hand and make my thumb move or make my finger move or make my toe move. It's not a big electrical stimulus, so my arms aren't flying around or anything like that. It's a small movement. And so what we do is we find where somebody's particular motor threshold is, we put it over the motor strip, and then we move the coil forward. And then we treat the part of the brain that we're interested in. Usually in the case of substance use disorders and psychiatric disorders, it's usually the prefrontal cortex or the front part of the brain. And, we provide stimulation. So the way it works is you go in, you put the coil over the motor cortex, the person who's delivering it will find the particular setting on the machine where your thumb moves or your foot moves, and then they'll move it to the place they're interested in treating, and it'll deliver a bunch of like taps in rapid succession. I've done it to myself a few times. And I also have 2 kids, 2 boys. And so it feels a lot like rubber band fights when you get hit in the head with rubber bands. It feels kind of exactly like that. The difference though is it's like in rapid succession. Okay. So sometimes people find it like annoying or aversive or irritating, usually in the beginning, but almost universally people get used to it over time. So I wouldn't say that it's not like fun per se, but it's fairly effective and really not that aversive.
So I have some experience working in a TMS clinic. And one of the things that I observed over the course of many weeks of somebody going in and getting treatment was that at the beginning sometimes, and this was for depression, it was many years ago when it was really depression and OCD, maybe a bit of PTSD were really all that was being explored. And people would come in a state of catatonic levels of depression. And then over the course of, say, 12 weeks, they're flourishing as people. And one of the questions that I've then gotten over the years is, well, does it change people's personality? Does it change who you are? Do you have any commentary on that?
Yeah, I get asked that. I get that a lot. And it's not going to change your personality or change who you are per se. I mean, if you have somebody who's been depressed for a very long time, or let's say you have somebody who's been depressed and they've been treated, but it's always been kind of a partial treatment and maybe not that effective. And then you give them a treatment that is very effective. Does that change their personality? I mean, it might be the way that they've been for a long time. If you've been depressed for a long time, a lot of these, it becomes habitual, right? Like sort of always feeling down, not really sleeping well, not really feeling like doing anything, not engaging in life, not doing anything socially. And then if you treat them and now they're doing more things, they're more social, or they're doing things differently, is that a change of their personality per se? I would say no. I think the personality is still lying, underneath, and what you're doing is just sort of lifting the psychiatric disorder and letting it come through.
Perhaps the difference of not changing who you are, but how you are.
Right. That's a good way to put it. Yeah.
And I meant to ask prior, but would you say, is TMS always concurrent with imaging? So you're always running an EEG or something at the same time to target the different regions?
Not clinically.
Okay.
Clinically, it's usually not. Sometimes people might use imaging to do neuronavigation, but not necessarily all the time.
Okay.
So it depends on the type you're using, but usually you don't have to.
So when delivering TMS, how are you ensuring you're getting to the correct region that you're intending?
So there's different ways of doing it. You start with the motor strip, so you know where the motor strip is, and you sort of know where you want to go forward from that. Some TMS does use the person's MRI to measure exactly where it should go. That's called neuronavigation. We're using the MRI and you measure it exactly and you move the coil exactly where it needs to go. It's expensive and it requires special equipment.
Okay.
Sometimes people there's this other system where you can use EEG coordinates and put them into a software and do that. Sometimes people just use a measuring tape. There's different ways of doing it. When we talk about the H-coil, which is kind of a more broad bilateral coil, it actually it's like inside a helmet. So if you remember those old-fashioned hair dryers that, it's like that, but really, it's really tight on the head. And you make sure it's really tight and you just sort of shift it forward. And because it's more broad, you don't have to worry as much about whether or not you're in the right place because the stimulation is more broad and more deep. So you just have to be pretty close.
Okay.
And you're going to be okay.
So then granted TMS is, again, not necessarily the most pleasant to experience, not terrible, but not pleasant.
Nobody loves it.
Nobody loves it, but you don't necessarily hate it.
Right.
Have you looked at other treatments like TFUS or TDCS or things like that?
I really have not.
Okay.
I haven't looked at those. We have a study a pilot study that we just finished. We're looking at non-convulsive ECT for chronic pain with depression and substance use disorders.
Okay.
So with this, we decided to do a clinical trial where we took patients who seem to be the most refractory. So we have patients who have chronic pain. They're not getting better from anything. They also have comorbid depression and they can have a substance use disorder. So normally they're not included in a clinical trial. But in our pilot study, we had them come in. They came into our research unit and we did ECT or electroconvulsive therapy, but with no seizure. So essentially what we did is we just turned the dial really far down on the ECT machine and delivered brain stimulation. You still have to have sedation, but you don't have to have as much anesthesia as you would require with ECT. And when there's no seizure, there's no cognitive effects. It doesn't have any impact on memory.
Okay.
So we did this study. We had 6 people come in and they did really well. They didn't have no cognitive effects whatsoever. Because we didn't cause a seizure, we used pretty mild anesthesia. So we just had them sedated, stimulated, woke up, and they woke up really very clear. Usually with ECT, people take a little bit of time to recover because of the seizure. So this was sort of a very promising direction for us because at least in medical school, we're always taught for ECT to be effective, you have to have a seizure. And it might be true, but it might not be true. So we were inspired by TMS and other types of brain stimulation that showed that you don't have to have a seizure for efficacy. So we decided to take among the most refractory patients that we have and give them the broadest stimulation that we could give them without causing enough side effects to see if we had an effect.
Fascinating.
So that's where the pilot study's done, and now we'll try to move forward to a clinical trial.
It's really cool to hear that this intersection of multiple comorbidities, which would often limit people from being in a trial, is now being recognized enough to have its own trial.
Right. Yep.
Very cool.
We wrote the grant. It was funded by the Department of Defense, and they wanted studies in chronic pain. And when I submitted the grant, I'm like, they're never going to fund this because I'm a psychiatrist. Like they're going to think I'm out of my mind, and they didn't. They thought it was a great idea. So
that's awesome.
That was good. Yeah.
It's hard to ignore the concept of relapsing when looking at substance use disorders. With TMS, is this something where patients can expect having to come back for periodic tune-ups, if you will?
Probably. I would think so. One of the advantages of TMS for depression is, sometimes people come back for tune-ups for depression as well. But oftentimes, like if you treat somebody with TMS and depression, you can put them on an antidepressant medication. You might not need as much TMS in the future, or sometimes none. In the case of cocaine use disorder, we don't have a medication. So the likelihood that we will need some sort of maintenance treatment is pretty high.
Okay. And of the studies that you've done, is there anything you could share that's been the most surprising to you?
I think what I would say is that the work that has been the most surprising to me actually comes back to comorbidity. For example, we have a small study that we're getting off the ground with TMS for smoking cessation, where we're adding the previous study that did TMS with smoking cessation, which was a huge clinical trial, did not include medication. So we're doing a study with TMS plus medication, meaning nicotine replacement therapy, like a nicotine patch, or varenicline, previously called Chantix. So we're combining medication and TMS to see if we can have a more effective treatment for smoking cessation. And what has struck me the most as we've started getting that study ready is that, as you improve people's depression or you improve their smoking, the other thing gets better.
That's excellent news. So then as we look to maybe 10, 15 years into the future in the work that you're doing, what are the comorbidities like this or specific conditions that you're most hopeful for TMS to be a strong application for?
I think that I would love to see TMS used more and more for patients who have comorbidities, who have psychiatric disorders with substance use disorders together. I would love to see it for substance use disorders as well, too. I would love to see it more accessible. At this point, I don't think any insurance reimburses for TMS or smoking cessation. I may be wrong, but I'm pretty sure not. I certainly know for a fact where I live in New York State, TMS is not reimbursed yet by Medicaid. I've been talking to powers that be at the state. I know they're interested in trying to move in that direction. So one thing I would love to see with TMS just overall would be just greater access to care. That not be so limited to what state you live in or what kind of new insurance you have, that you would just be a treatment that's just available sort of like the way antibiotics are available.
I want to thank you for being here. This is the first episode we've done on TMS, so I'm really excited to build some awareness in the INS around TMS.
Great.
Do you have any recommendations for where people can go to learn more about TMS if they're curious?
Oh, the TMS Clinical Society has a great website.
Excellent. Perfect. Well, thank you so much.
Thanks.
Appreciate you being here.